good afternoon, and good evening to our speakers, chairs, and audiences of the ACNS webinars. Different parts of the world, we are back again with another session of ACNS webinars for you. The first speaker for today is our honored guest from the USA, Dr. Angela Richardson. She is an assistant professor at the Department of Neurological Surgery at the Indiana University, Indianapolis, USA. After finishing her residency and fellowship in surgical neuro-oncology at the University of Miami, she did her second fellowship in cerebrovascular and skull-base surgery from the University of Wisconsin with Professor Baskaya. She has received several meritorious awards for her outstanding performance in neurosurgery academics. She is a member of the YNS committee of the ACNS as well as the ACNS. She is a noted author with several publications and book chapters in distinguished journals and textbooks, including the famous book Sweet and Schmidek. We are extremely honored to have her today as a speaker at our webinars, and today she'll be talking about thalamic gliomas, operating nuances and outcomes. The speaker for the second session of today is our honored guest from Palestine, Dr. Jamal Goshe. Dr. Goshe had his neurosurgical training in the UK and Ireland at Queen's Medical Centre, Nottingham, and National Hospital Neurology Neurosurgery, Queen Square, London, with main interest in epilepsy and spinal neurosurgery. He expanded his neurosurgery further by serving at the King Faisal Specialist Hospital in Riyadh, where he was the active member of the comprehensive epilepsy surgery program. He was previously employed at the MIH Hospital, Jerusalem, as a consultant and chief neurosurgeon. Currently, he is the director and chief of GMSC in Palestine. He is a founder of the London-based International Physician Across Continents charitable organization that serves over 40 countries across the world over the last 18 years. We are extremely honored to have him today as a speaker at our webinars, and today he'll be talking about neurosurgery in resource-limited settings and disaster time. The chair for the first session of today's webinar is our distinguished faculty from Japan, Professor Yoshitaka Narita. Professor Narita is a professor and head of Department of Neurosurgery and Neuro-Oncology at the National Cancer Center Hospital, Tokyo, Japan. He is the co-chair, Neuro-Oncology Education Committee of the WFNS and director of the Japan Society of Neuro-Oncology and the Japan Neurosurgical Society. He also serves as the head of the Committee of Brain Tumor Registry of Japan and Committee on Guidelines. He also serves as the director of Japan Society of Intraoperative Imaging and Japan Awake Surgery Association. He specializes in the treatment of gliomas, malignant brain tumors, neuro-oncology, and molecular biology. We are extremely honored to have him today as a chair for the session of Dr. Angela Richardson. The chair for the second session of today is another distinguished faculty from Indonesia, Professor Abdul Hafiz Bajmal. Professor Bajmal is the professor of neurosurgery at the Airlangga University, Indonesia. He is the president of the Indonesian Neurosurgical Society and also served as the past president of the Southeast Asian Neurosurgical Association. He is a member of the WFNS and its spine committee as well. He is a noted academician and serves on several editorial boards of distinguished journals.
So good afternoon and good evening. I am Dr. Narita from National Cancer Center in Japan. So the number of COVID-19 patients in Japan is still increasing, about 1,000 to 2,000. Not so many, even before Olympic Games Tokyo 2020. However, surgery for malignant brain tumor is performed as usual. Today, Dr. Richardson will give a lecture about thalamic gliomas. So I will share one slide. So a surgery of thalamic glioma is one of the most difficult procedure. This figure is cited by Dr. Sinlon from World Neurosurgery last year. So two major approach, medial and lateral approach, is usually selected for resection of thalamic gliomas. So today, Dr. Angela Richardson will give a lecture about the resection of thalamic tumor. So let's start the lecture, please.
All right, Dr. Narita, arigatou gozaimasu. Thank you for having me here today. Today I'll be talking about thalamic gliomas, surgical approaches, nuances, and outcomes. This is work that I did with Dr. Baskaya at the University of Wisconsin, and now I'm transitioning to a new position in Indiana. So I have no disclosures. Thalamic gliomas, we know, are relatively rare tumors, making up 1.1 to 5% of all intracranial tumors. They're more common in children than adults, and so often seen more commonly by our pediatric colleagues. They do tend to be associated with poor outcomes and are often thought, or at least in the past, to be inoperable. Surgical resection historically was associated with high morbidity and mortality, high complication rates. And because of this, typically stereotactic biopsy and adjuvant treatment were the standard of care. However, we do know that maximal safe resection and extent of resection is the standard treatment for gliomas and other locations, and extent of resection in particular is associated with improved survival in multiple studies. And this, of course, is followed by adjuvant therapy for many high-grade tumors. So why in the past have these tumors been considered inoperable? Well, they are in a deep and difficult to access location. The thalamus, we all know, is important as a motor and sensory relay. And there are many surrounding vascular structures, including the internal cerebral veins, the thalamostriate veins, approaches through the Sylvian fissure involve the branches of the MCA. And there's uncertainty regarding the influence of surgical resection on prognosis. There aren't large studies that have compared the resection of thalamic tumors with appropriate control groups. And justifiably, there's concern regarding complications from resection. So the real questions are, do the benefits of resection outweigh the risk? Can we improve survival without significant complication burden? And in general, when we talk about resection of gliomas, we talk about indications for surgery. So tissue diagnosis is a very important indication. This allows us to perform molecular phenotyping and histologic analysis so that we can reach an appropriate diagnosis and appropriate treatments to follow. We do know that biopsies are subject to sampling biases. The question of, does this improve prognosis? It can in other areas of the brain. So is that true in the thalamus as well? If symptoms are due to compression and not invasion or infiltration, resection has the possibility of alleviating these symptoms. And we can also potentially reduce vasogenic edema, allowing patients to better tolerate adjuvant therapies such as radiation. So to the question of, does surgical resection improve prognosis in these tumors? This is a recently published article from the Journal of Neuro-Oncology, where they looked at 102 adult thalamic glioma patients. 61% of these were glioblastoma, and they had a median survival of 13.6 months. They did look at extent of resection, comparing gross total resection, or GTR, and near total resection, or NTR. This was achieved in 45% of patients, and this was compared with subtotal resection, which was seen in 49% of patients. And when they did gross total or near total resection and adjuvant therapy with chemoradiation, they saw improved survival compared to the other treatments. And this was independently associated with survival with a significant p-value. You can see the Kaplan-Meier survival curve here on the right, with the subtotal resection in orange and the gross total or near total resection in blue, demonstrating a benefit to survival with increased extent of resection. However, the study did not include a comparison group for biopsy only, but it does indicate that greater extent of resection does appear to be favorable for prognosis. So how do we safely access the thalamus for surgery? Dr. Spetzler described surgical approaches for thalamic cavernomas in 2015. You can see here across the bottom different views of the thalamus with the shading indicating the surgical approach used for these regions. So he defined 6 regions. Region 1 was anterior inferior, and that was approached by an orbitozygomatic approach. The medial area in lavender was approached by an anterior ipsilateral intrahemispheric approach. The brown lateral surface was approached by an anterior intrahemispheric approach, but from the contralateral side to increase the working angle. The posterior superior aspect could be approached by a posterior intrahemispheric approach, suited well for the pulvinar. The lateral posterior inferior by a parieto-occipital transventricular approach, and the medial posterior inferior by a supracerebellar infratentorial. And this was a patient series looking at 46 patients. 87% of these had MRS of 0 to 2, and 91% of patients were unchanged or improved compared to preoperatively. And so these were the outcomes reported following resection, sorted by region and approach. So the number of patients in each category is indicated, and the initial neurodeficits or worsening of pre-op deficits postoperatively, you can see affected a significant number of patients, with a significant number of patients experiencing hemiparesis or hemiparesthesias and some cranial nerve palsies as well. But what's most interesting here is looking at neurodeficits at the end of the study. The column on the far right shows that although many patients have new or worsening deficits postoperatively, the large majority of these improve, and patients do seem to do quite well. However, that was in cavernomas. So do these results apply to resection of gliomas? Well, there are several key differences here. Cavernomas have well-defined borders. Generally, gliomas can be infiltrating and extend into adjacent areas. The cavernomas typically won't extend into neighboring areas, and cavernomas will typically be smaller in size. Some of these gliomas can grow to very, very large size, extending into multiple areas. So we hypothesize the correct selection of surgical approach, resection of thalamic gliomas can safely be performed and may improve outcomes. So what surgical approaches are suitable for these tumors? Well, we know Professor Yassergill has divided the thalamus into 4 surgically accessible surfaces based on fiber micro dissection and topographic analysis. You can see in yellow the lateral ventricle surface. In red, he describes the velar surface, more medially the third ventricular surface, and posteriorly the cisternal surface. However, he does not describe lateral approaches in this particular paper. So we performed a novel hypothesis-free topographic analysis by segmenting the white matter tracts in the thalamus, marking the vascular structure surrounding the area. And this was a 3D virtual model-based identification of these surgical approaches with the topography used to identify the thalamic regions that would be accessible via each approach. So this is similar to Dr. Spetzler's work, however, it does have some differences. You can see the anterior intrahemispheric approach is shown for the more anterior aspect, and the medial aspect of the thalamus. You can see on the left at the bottom of the screen where one hemisphere of the brain has been removed, the cones indicating the trajectory to access each of these regions of the thalamus, and then the views of the thalamus demonstrating the corresponding area that would be accessed by each of these approaches. And here we have the TransSylvian Trans insular approach in light blue, allowing access to the lateral surface, Transtemporal, Transcelcal for a more lateral inferior access, the Occipital Intrahemispheric, and the supracerebellar Infratentorial, quite similar with the prior, and the superior Protolobial approach from the posterior aspect. So just to go through some of these approaches, the anterior intrahemispheric approach, you can see here the trajectory over on the left, and then a view down, sort of the cone, showing you the access to the thalamus. We all know the trapdoor incision you can perform. You can also perform a linear incision. The coronal suture and sagittal suture are marked here on the skin. You can see them on the bone as well. And surgical positioning for this approach, as well as the posterior intrahemispheric, is something that is often talked about. So the neutral position can be performed, and this does leave us with a really good anatomical orientation. With the head position neutral, you know exactly where the falx is, where you're coming down, and the angles are much easier to understand. However, this can be problematic, requiring more retraction on the brain itself, and that can lead to stretching of these draining veins, which you can see here. We tend to perform an ipsilateral side down approach. Once the arachnoidal adhesions between the brain and the falx are lysed, the gravity is able to serve as a retractor and pull the brain away. This enhances the operative window in this intrahemispheric approach and really gives good access with minimal to no retraction on the brain itself. In the posterior intrahemispheric approach, this also works in terms of positioning, although there are some proponents of a sitting or semi-sitting position, and that can be used in certain cases as well. So here are some dissection pictures of the anterior intrahemispheric approach. You can see coming down along the falx, the pericallosal arteries at the depth of the field and the bright white of the corpus callosum. Collosotomy is performed, and that gives access to the lateral ventricle. And as we all know, important to ensure that you're in the appropriate lateral ventricle based on the anatomy of the veins and the choroid plexus. Intraoperative navigation is a useful adjunct here as well. And then from there, you can do a transchoroidal or transfornicele approach and access the third ventricle where that is indicated. So a case example here, and a picture just demonstrating the transforaminal, subchoroidal, transchoroidal, interfornicele variations. This is a case of a 61-year-old male who presented with confusion, slow speech, and a mild hemiparesis, has this large enhancing lesion of the left thalamus, underwent an anterior intrahemispheric transcallosal approach. Let me know if the video is not working, but here you can see performed ipsilateral side down, the pericallosal artery and the corpus callosum. Lysing the arachnoid over the corpus callosum allows retraction of those vessels, dividing the corpus callosum and entering the lateral ventricle. Here we can see the tumor, and then exploring further the foramen of Monroe, defining the borders, choroid plexus, separating from the fornix. And then as we continue dissecting, finding the hemorrhage in the tumor, that can easily be removed. And then continuing to work, defining the borders. And as we're able to resect tumors, send several large specimens for pathology. Performing debulking. Let's speed this up a little bit, but the ultrasonic aspirator is a great tool for debulking of these tumors, particularly at low settings. It does allow protection of surrounding structures and vessels. Developing that plane. Good anatomy here. You can see the mammillary bodies. And one thing to note in these cases where the tumors are likely to cause the development of hydrocephalus, either from tumor recurrence or with radiation therapy, you can perform a third ventriculostomy at the time of surgery and potentially, hopefully, avoid a shunt later in the course of the disease. Some more debulking here. Eventually able to see the cerebral aqueduct and resect the remainder of the tumor. We have a good view of the anatomy at the end of the case. And the patient did quite well. This has been published. It was a gross total resection. The neurologic exam was stable with a mild hemiparesis that was not worsened following surgery. And the pathology, unfortunately, came back as a grade 4 astrocytoma. Another case example was a 54-year-old male. He presented to us after initially being biopsied and shunted, having an Ommaya placed 30 years prior. He did undergo adjuvant treatment with radiation, and he had long-standing right-sided hemiparesis, severe hyposthesias, gait imbalance, and that was worsening. You can see here this cystic lesion with enhancement along the third ventricle. And so we went on to do the anterior intrahemispheric approach again. You can see the really thickened arachnoid here, likely as a result of the radiation and prior treatment. Just opening up that intrahemispheric area and really cutting the arachnoid along the veins, and that allows further retraction of the brain without stretching them. Here you can see the internal cerebral veins and the fornix, choroid plexus, coming around the catheter from his prior interventions. And there's the tumor. We're able to obtain specimens, continue working in this deep and narrow corridor. And there's the tumor. Again, sending more for pathology. And end of the case, this is where the arachnoid was cut to free the veins from both the falx, as well as freeing it a little bit from the brain and allowing that retraction without stretch and injury to these vessels. As we all know, that can be a major complication of the anterior intrahemispheric approach. So the outcome here was good, a gross total resection, which you can see comparing the pre and postoperative MRIs along the bottom, both axial, coronal, and sagittal. And the pathology here was a pilocytic astrocytoma, luckily for him. This brings us to the next approach, the superior parietal lobule approach. You can see the cone trajectory demarcated on the bottom left. And we all know the measurements for the superior parietal lobule approach from the the surface landmarks. You can see the craniotomy marked on the right side. And here with opening the dura. And this is, the trajectories here can be a little confusing. Intraoperative navigation is quite useful, bringing us to the ventricle and allowing us to identify these landmarks and do this approach safely. So case examples here, we have a 47-year-old male presenting with severe headache, short-term memory problems, and right hemi hypoesthesia. He had the MRI when we saw him, that's on the two images on the right side, that axial and coronal, demonstrating the significant hyperintensity of the left thalamus there, which you can see extending into the pulvinar. Interestingly, he'd had an MRI 2 years prior to presentation, and that's shown over on the left side. You can see the beginnings of that signal change posteriorly there. At the time, that was read as a small stroke. But by the time he came to us, it was clear this was a tumor. So he underwent surgical resection using the superior protolobial approach. This was grade 4 astrocytoma. He did have a temporary aphasia and right hemiparesis postoperatively, not surprising given the approach, but these did improve postoperatively. The next case example was a 25-year-old male who initially had presented with headaches. At that time, he was found to have a large cyst, and this was treated at an outside hospital with parietal craniotomy, biopsy, and cyst evacuation. He presented to us later with worsening headaches and dizziness. MRI showed this recurrent residual tumor and a significantly enlarging cyst that you can see here. Due to the prior craniotomy and the large cyst that extended fairly close to the surface, the superior protolobial approach was chosen here. And you can see the postoperative imaging, the enhancing tumor is gone, the cyst is decompressed. He was neurologically intact at follow-up, and the pathology came back as pilocytic astrocytoma. He's 88 months since resection now and has not had any recurrence. So in these tumors, complete resection can help significantly. The next approach we're going to discuss is the TransSylvian Trans insular approach. This is shown from lateral approaching the thalamus. You can see the bony exposure required and the burbles for the craniotomy. This allows you to access the sylvian fissure, and a very wide split of the sylvian fissure allows access to the circular sulcus and allows one to work between the MCA branches. So in this case example, the 16-year-old male who presented with left hemiparesis and dystonia underwent stereotactic biopsy and radiation in an outside hospital, was diagnosed with pilocytic astrocytoma, but had worsening dystonia when he started undergoing radiation therapy. And so here you can see a picture of him with left-sided facial droop, hemiparesis, and this tumor on the right side and extending down to the peduncle, both with the enhancing component and the flare signal change here. So given the worsening symptoms, surgical resection was recommended. Here he underwent a staged resection. So the first stage was a right terional craniotomy with orbitozygomatic osteotomy with a TransSylvian subtemporal resection. And he underwent intraoperative MRI during that stage. He was taken back as a second stage for repeat right-sided orbitozygomatic craniotomy, and intraoperative MRI ×2 was performed at that time. And I'll talk a little bit more about staging later in the presentation. But here you can see the preoperative MRI, the post-stage 1 after the second stage. And this was a WHO grade 2 astrocytoma, which was discordant from the pathology that was obtained from his initial biopsy, which I'll remind you was pilocytic astrocytoma. So this is the final postoperative scan demonstrating good resection of this tumor, which you can see there. Pressure on the surrounding structure has been relieved, and you can see that also on this flare image. And clinically, he was much improved here. He's tying his shoe, a simple day-to-day task we perform, but would have been impossible for him with the hemiparesis he'd had preoperatively. So he did quite well from surgery. And similarly, but to access lower lesions, the transtemporal transcelcal approach, here's one of the incisions that can be used here. And you can see the visualization of the temporal gyri and sulci. And here you can do a low approach if you go between T2 and T3 to avoid the optic radiations and entering the ventricle and access tumors this way. So this case example is a 63-year-old male, and he presented warm sensations of the right hemibody and a right superior quadrant tenopsia. And you can see the lesion here extending into the atrium of the ventricle of the left side. And when on examining the preoperative MRI, this sulcus here where the arrow is pointing to it was seen to be somewhat larger than the others, and the trajectory was right for the tumor. Therefore, we were able to enter this sulcus, and over on the left side, you can hopefully see these tenosutures being used to attract the pia, and that's something I'll show in a subsequent video. But as you dissect down to the depth of the sulcus, you can reach the tumor, resect it with the ultrasonic aspirator, and leave the cortex largely undisturbed. Postoperatively, had a temporary right hemiparesis that improved, and pathology again was a grade 4 astrocytoma. The occipital intrahemispheric approach is much like the anterior intrahemispheric, but coming from posteriorly. You can see the angle of approach here. Again, we tend to do this with the ipsilateral side down, but can be performed sitting or semi-sitting. And as you approach along the falx here, you can see the bright white of the splenium, of the corpus callosum, with the quadrigeminal cistern underneath, the medial posterior choroidal arteries, the telechoroideae, and you can see the pineal gland, the posterior third ventricle, the internal cerebral veins. So this gives good access to the posterior portion. In this case example was a 26-year-old female who presented with memory problems, double vision, personality changes, had this large lesion that appears bilateral with enhancement, but primarily centered on the right side with extension to the left. So she underwent an occipital intrahemispheric subsplenial approach. In this video showing the approach along the falx and the bridging veins, dividing those from the falx as possible. Again, sometimes when you get into the case, you see these bridging veins and they appear to just be crossing and completely obscuring the view, but with some time and patience, often they can be freed up and allow at least some small working windows. And here dissecting down, we're able to see the tumor at the depth of the field. Continuing working to define the borders. And you can use retractors on the falx. Sometimes these can be very helpful in providing a increased working window, although sometimes they can sort of limit your mobility. Continuing to work around the tumor and perform some debulking, defining the edges, pulling it into the field. Let me speed this up a little bit for the sake of time. The ultrasonic aspirator again for debulking. There you can see the internal cerebral vein as we continue working. We're able to visualize more and more of the tumor. Again, just continue in this fashion, debulking and dissecting, always staying aware of the anatomy. Until here, we're in the lateral ventricle, choroid plexus. With the visualization of some normal anatomy, it's always reassuring at this stage in the case, allowing you to sort of work in a more efficient manner. Resect the tumor and obtain hemostasis. So surgical outcome was good. She had a mild left visual field deficit, not surprising with the occipital intrahemispheric approach, but was otherwise neurologically intact. Pathology unfortunately did come back as a grade 4 astrocytoma, and she deceased at 44 months postoperatively. I think we'd all agree with a GBM like that, survival to 44 months is probably better than most of us would have expected. And this is her postoperative scan, demonstrating the complete resection of the tumor. And this was even her scan at 41 months post-op didn't really show significant recurrence, and she was still looking very well clinically at that time. So she had a significant number of months of good quality of life following this resection, which in these patients where we know disease progression is pretty much inevitable is an important consideration. And then the supracerebellar infratentorial approach is for these posterior inferior lesions. And you can see the trajectory here showing the superior and inferior colliculi and the incision, typically a linear incision, And you want to do a torcular crossing craniotomy, which you can see here. And then by lifting up the tentorium, always need to be on the watch out for these draining veins and lakes in the tentorium. If you do need to cut the tentorium, these can be pretty troublesome. But this does give you access to the pineal gland. You can get to see the internal cerebral veins, the basal vein, the internal occipital veins. This is a pretty versatile approach for these posterior inferior lesions. So this is a 30-year-old female with a 6-year history of progressive headache and nausea. And she was previously biopsied and radiated for what at the time was a grade 2 astrocytoma. And you can see her imaging here with some enhancement. And you can see on the sagittal how this lesion is good for a supracerebellar infratentorial approach. And you can see here, she was neurologically intact after surgery. However, at this time, this was now a grade 4 astrocytoma. And so I'll talk a little bit more about staging. It's something that I alluded to earlier for maximal safe resection. So you can do multiple stages for these tumors, and that can be either through the same approach or a different approach. You know, we don't necessarily want to put a patient through a second round of anesthesia, but with some of these approaches, you're working through these small working windows, and particularly depending on the tumor consistency, if it's of a firmer consistency, it may be outside your working window. And without the inability to pull on it and cause some damage outside of the field that you won't be able to control, it's difficult to reach all of the tumor. However, sometimes post-operatively, 1 or 2 weeks, the brain has now pushed the tumor back into the area that's accessible via that window, so that same approach can be used. Or for these very large, extensive tumors, a different approach can be used when the tumor is out of view with that approach and another trajectory is required. And if this can be done safely, then this may help with patient outcomes. So here's one example of this, was a 31-year-old female with a 3-month history of progressive headache and resting tremor, had this large right-sided tumor. And she underwent a first stage right-sided anterior intrahemispheric transcallosal approach. And I haven't talked a lot about it, but did have intraoperative neuromonitoring with MEPs, SSEPs, and subcortical stimulation, which can be very useful in these cases. And then as a second stage, a right-sided temporal craniotomy and Transcelcal transtemporal approach, again with neuromonitoring. And so you can see the preoperative MRI with this large right-sided tumor. After the first stage, there was some residual tumor that was difficult to reach due to its depth on the working windows afforded by the draining veins. However, after the second stage, this was a largely complete resection, and this did turn out to be a WHO grade 4 astrocytoma. This was the 7-month follow-up scan, and she did neurologically well from this. This is another case example, a 19-year-old female. She was a trap shooter. She was previously biopsied in an outside hospital and diagnosed with infiltrating glioma, which was not able to be further characterized based on those samples. She had a right-sided hemiparesis that progressed to hemiplegia, particularly affecting her right upper extremity. And she had a Cushing syndrome secondary to the large amount of steroids she was on to control her symptoms. So she underwent a TransSylvian Trans insular approach in 2 stages, which I'll show you here. The dural opening, the TransSylvian Trans insular approach, splitting the Sylvian fissure, which I won't belabor as we're all familiar with this, but peeling and cutting to open there. And the wide Sylvian fissure split that's required for these transinsular approaches. And here is the use of these tenos sutures to retract on the pia. This allows you to free up your hands to be operating without having to retract as much. And this has been previously published as can be a very useful surgical technique. And then as you get down to the circular sulcus, bring up the area and the transinsular approach and identifying the tumor here. And again, her first pathology from the biopsy wasn't particularly conclusive, so obtaining large specimens for pathology, debulking the tumor, dissecting around it, taking care to preserve any passing vessels, subcortical stimulation, and additional shaving where possible. And additional debulking. And so we're doing that in stages to allow the most complete resection possible. can see here, and she was brought back for a second stage for a more complete resection. Done through the same approach and shortly after to prevent scarring from occurring. So she underwent a near total resection, and this actually came back as a WHO grade 2 diffuse astrocytoma. And you can see the picture of her on the left here. She was pretty Cushingoid, and by the time she came back for follow-up on the right, she was off steroids and had lost significant amounts of weight. Her right upper extremity had improved. She did have persistent weakness of the distal right upper extremity, but her neurologic exam overall had improved, and she's had no recurrence, and now she's over 3 years post-operatively. And I think this is going to be the last example I have for you guys. A 6-year-old male presenting with headache and new onset left hand intention tremor and clumsiness. He had previously been biopsied and shunted in an outside hospital and now had this very large tumor, the right thalamus. He underwent a 2-stage transtemporal transcelcal approach. And you can see this here. This is a long video, so I'm just going to speed to some of the highlights. Again, cutting the arachnoid, opening the sulcus. We've seen this before. These teno retraction sutures to help free up the hands. And just a very wide sulcal opening. You can see here using the intraoperative navigation to ensure a good trajectory towards the tumor. And then continuing to split the sulcus. And it's important to avoid having some tunnel vision and only doing a small split of the sulcus, as this can lead you to damage the surrounding brain as you retract. But as you get down to the tumor, again, the same techniques of debulking, obtaining large specimens for pathology, continually checking with the navigation, some cortical stimulation, and working to remove the tumor. Again, with the ultrasonic aspiration, continuing to check our trajectories. This area of the tumor looked a little bit different, so more pathology specimens were obtained. As we know, these tumors can be spatially heterogeneous, so important to obtain multiple samples from throughout the tumor to get the most accurate diagnosis and trying to avoid sampling bias. So the resection cavity is widening and widening as we take out more and more of the tumor. And this actually just underwent a second stage to get the residual that was unable to be reached from the first stage. So let me skip to the outcome here. Gross total resection, get an improved neurologic exam. It was a WHO grade 4 diffuse midline glioma, which is the H3K27 mutation. However, he has no evidence of recurrence at 14 months of follow-up, which is, I think, quite good for this disease and is continuing to be closely followed. So the more important question, even if we can do this, I've shown you a few cases where patients have done okay, is this beneficial in patients? So this is a single surgeon series retrospective review over 2 years, and this included only patients who underwent a significant resection of greater than 80%. So patients that were biopsied or underwent a very subtotal resection were not included, and included only glial tumors. 42 patients, mean age was 35, 30% of patients were pediatric, and a very significant proportion, 45 of them, had previously been biopsied. So here are the patient and tumor characteristics. Clinical presentations were similar to what's been reported in the literature, with headaches and motor deficits leading the way in terms of symptoms. The tumors were quite large, mean size of 4.4 centimeters. Sorry if my cat's loud. Hydrocephalus was present in a significant proportion, and you can see the histologic grade here with 53% of patients having grade 4 tumors. So we were able to look at the demographics of the high grade and the low grade patients, and you can see here there were significant differences in the age. High grade tumor patients tended to be older, which I don't think is a surprise. High grade patients, if you look lower down, I don't think I can have a pointer. Those with good MRS is defined from 0 to 2. Post-operatively, there were relatively equal proportions. However, at 6 months, there was a significant difference where low-grade tumor patients had pretty much universally good MRS, whereas the higher grade patients, that was not true. And then particularly last follow-up, And I'll show you some figures that demonstrate this. And again, the length of follow-up was significantly longer in the low-grade tumors, but that's due to their improved survival. So in terms of the surgical treatments that were used, the most common approaches here were the transtemporal and the anterior intrahemispheric approaches, and the extent of resection with gross total and near total adding up to about 65%. So the question, are these surgeries safe? Well, we didn't have any operative mortalities. In terms of new postoperative deficits, 70% of patients did not have new postoperative deficits, 27% had temporary, and permanent was 2.5%, which was that one young lady I showed you, the trap shooter, who did have that right upper extremity weakness, which she had preoperatively, but improved again, except for the distal right upper extremity, which has remained weak to this day. But pretty much other than her, everybody else improved in the postoperative period, and 2 patients did require shunt placement for hydrocephalus. So in talking about these patients, we can talk about both survival and quality of life. So we chose to look at quality of life as disability using the modified Rankin score. And surgical resection in low-grade tumors does not induce disability. So you can see here, MRS is from 0 to 6, 6 being death, 0 being completely independent, and the grades in between. Preoperatively, the large majority of patients were grades score 0 to 2. And postoperatively, that was maintained, although some patients had a little bit of increased disability. However, at 6 months postoperatively, that had improved, and that was maintained through last follow-up. So these low-grade glioma patients actually had improved disability scores following their surgical resection without significant worsening. However, that wasn't true in high-grade gliomas, or at least it wasn't sustained. Preoperatively, these patients had more disability than the lower-grade glioma patients, but did see some improvements in the initial postoperative period. And the large majority of patients still had good MRS at 6 months postoperatively, but at that time and then progressing through last follow-up, they had increasing disability, and that was due to progression of their disease. And again, I don't think that's surprising considering the nature of that disease. But we certainly weren't hurting these patients with the surgery, and potentially were improving their quality of life. I think this, for a real comparison, would require a group that was biopsied and then just had adjuvant therapy to obtain a real comparison, because I think the rate of decline without surgery might certainly be faster. But what factors were associated with a good MRS, again, defined as 0 to 2? We performed a univariate analysis looking at this cohort of patients, and we saw that age less than 40 years old was favorable for a good MRS, as was lower grade tumors. These other variables, even size greater than 4 centimeters, did not come out as significant. Neither did left-sided tumors. Patients with multifocal disease, somewhat surprisingly, did not have worse MRS. And then when we performed the multivariate analysis, the only thing that came out of statistical significance was that high-grade tumors were associated with worse MRS. And again, I don't think that's surprising. So we went on to look at surgical outcomes, and I think this is an important point. Tissue diagnosis is something I talked about during the case examples, and 45% of these patients were previously biopsied. When we went on to do these more complete resections and sent larger samples to the pathologists, following these resections, 30% of those patients had discordant pathology from their initial biopsy. So there's definitely significant sampling bias with needle biopsies, which we all know, but I was a little bit surprised to see that it had affected about a third of these patients, and it was always higher grade tumors. We were also able to do some molecular analysis that wasn't done on these initial samples. The number of patients is quite small, so can't draw any large conclusions from that. There are only a couple of patients with the H3K27 M mutation, and we had no IDH wild type in the patient, or no IDH mutants in the patients that we were able to have molecular phenotypes for. 51% of the patients did have GBM, and overall survival was pretty good for low-grade tumors and was still quite good, I think, for high-grade tumors considering the natural history of that disease. And so we want to examine what variables might be associated with survival. We looked at age of age at the time of surgery, and those patients less than 40 years old had improved survival. This is months on the x-axis, and tumor grade, not surprisingly, was again associated with patient survival in these Kaplan-Meier curves. And we also looked at extended resection. When we looked at the total cohort, the p-value was 0.067, so not quite reaching statistical significance. However, those with a gross total resection did tend to do better. When we stratified and looked only at the high-grade gliomas, that statistical significance improved and was significant at 0.03. For those undergoing a gross total resection did have improved survival. And the tail of patients there, you can see, had a much improved survival as well. So we went on to perform a proportional hazards model as a multivariate analysis and looked at these variables. And high-grade tumor did have a higher relative risk, as did multifocal disease. A significant portion of these tumors can be sort of bilateral or multifocal, and that is associated with higher grade tumors. So I don't think that association is surprising, although these are independent effectors. And gross total resection was protective in this model. So we know independent poor prognostic factors in Thalamic are multifocal disease, high-grade tumors, and incomplete resection. This is a very busy table, just sort of summarizing some of the literature on resection of Thalamic and survival. And then just to touch on a couple more quick points in the last couple of minutes. In terms of surgical tricks for Thalamic or nuances that can help, one is you must know the anatomy. You must really look at that preoperative imaging, plan an appropriate approach, and that's based on the tumor location and its extension. If you can come along the longer axis of the tumor, it's going to provide you with more working room, and just, you know, DTI imaging to help identify the position of the internal capsule and the motor fibers, use of intraoperative adjuncts, MEPs and SSEPs, subcortical stimulation for the corticospinal tracts, intraoperative navigation can all be very useful. We talked about staging to allow maximal safe resection. Again, if this can be done safely and if it can be done in a timely manner, you certainly don't want to delay adjuvant therapy on some of these higher grade tumors significantly to do additional stages as the tumors can progress in that interval time. But this can be done via the same approach if the residual tumor has been pushed into where that view would be, or a different approach if it provides better access, and no or minimal use of continuous retraction. So some pitfalls of operating on the Thalamic gliomas. In general, avoiding cortical entry when possible, using their natural arachnoid spaces, the intrahemispheric fissure, transcelcal dissection, the Sylvian fissures, limiting it to a single stage. If you do a resection and it's a grade 4 tumor and there's a small amount left that's accessible, if that can safely be removed, that might be worth it if it can improve survival. And again, short intervals there to prevent scarring. The superior parietal lobule approach can be quite challenging. It's a very long reach. The instruments don't always reach as far as you'd like them to, so that can be particularly difficult. So just measuring that out ahead of time and being sure you're gonna be able to reach what you need to reach, and avoiding venous injury. Both of the superficial veins, again, these intrahemispheric approaches, that can be where a lot of your complications come from, as well as the deeper veins. So in conclusion, maximum safe resection can be achieved in Thalamic gliomas. Gross total and near total resection was possible in 65% of patients in this series. And it can provide the best possible outcome, particularly for young patients with lower grade gliomas, but also can extend survival, it appears, in higher grade tumors. Although the role of maximal safe resection and the length of survival on high-grade gliomas does remain difficult to determine. This is a small group. It is a retrospective analysis, and we don't have a contemporaneous comparison group treated with partial resection or biopsy here to compare either the MRS outcomes or survival. So I'd like to thank you for your attention and just acknowledge those who contributed to this work. And I think that's about time. So I'd be happy to take any questions.
Okay, thank you for your nice lecture. Yeah, maximum safe resection is very important, even for thalamic gliomas. Do you have any questions from the audience?
Yes, definitely. We will start with inviting comments. Yes, Liu?
Yeah, thanks, Raja. Thanks, Professor Angela, for a very nice, comprehensive lecture. I have a few questions to ask. Do you observe any form of plasticity for thalamus? Because I know it's difficult for us to check clinically about sensory or even visual, but do you come across this, especially in local glioma? And then what do you think the prognostication for those tumors that are extending into the cerebral peduncle and also the hypothalamus? And you never mentioned about use of fluorescent. May I know, is that useful in your case series? And then for your TransSylvian approach, do you think that any form of monitoring of the hypothalamus in that approach beside corticospinal tract? Thank you.
Okay, I think I missed one of those, but let me answer the ones I remember, and then you can ask again. In terms of plasticity, we haven't really been able to observe that aside from seeing how people recover. And I think that's tough to tease out plasticity from just, was this compressing but not infiltrating those tracts? It's not, you know, like Hugh Defoe's work where he is able to do repeat resections and map and see how things have moved around. I think that's a little more difficult in these deeper tumors, so not something we've been able to assess. In terms of prognostication, with tumors involving the peduncle, I think there was one thalamopeduncular tumor I showed in that young boy, and he did quite well. Again, I think it just depends on sort of the type of tumor. I would hypothesize that lower grade tumors are more likely to displace sort of those important tracts as opposed to involving them, more like the high grades. At least that's what we've seen sort of in these lobar tumors. So I would hypothesize that, but I don't have any direct evidence. And I haven't seen too many complications from hypothalamic issues or involvement. One thing is that occasionally patients will be very slow to sort of wake up after these surgeries and be just very almost abulic, but it's not frontal. They just don't want to wake up. They don't want to participate in therapy. They don't want to talk. And that usually resolves over the first week or so. And that could be due to a couple of things, the, you know, role of the thalamus in alertness and interaction. Also, we do typically put these patients on a fair amount of anti-epileptics because these can be epileptogenic surgeries. We typically do monitor them, particularly if they're slow to wake up, with EEG. But we've definitely had patients who were kind of in that slow to mobilize path that did not have seizures, and just eventually just sort of come out of it as they improve post-operatively. And what was your for the TransSylvian, we do monitor just the subcortical stimulation and the motor pathways with MEPs, SSCPs.
Right. How about 5 ALA, Professor, in thalamic glioma, especially those 45% that you biopsy?
Yeah, we haven't used that. I think it could be a useful adjunct. I've used it a little bit here and there, but not in these deeper tumors. I think it'd be a little bit challenging to really get that visualization, but it would be a good idea to try. Especially I think in the lower grade tumors where it's harder to differentiate the tumor from the surrounding tissue. Although then it doesn't always show up, so.
Thank you very much, Professor.
Thank you very much. May I ask Professor Richardson about the staging of resection that you showed us? What was the reason for staging? Was it due to the tumor went into inaccessible corridors, or due to there was some variations in the neuromonitoring systems that you were doing for these patients?
So mostly the first. So either, you know, for these intrahemispheric approaches, sometimes if there's too many veins, you have these very small working windows. And if the tumor's of a firm consistency, it's very difficult to sort of pull it into that area. So in an initial resection, you may be able to get some of the tumor, but then on the postoperative MRI, there's just stuff that was out of reach. And so re-imaging them in a week or two, that may have, the brain starts to push back on that tumor and push it more into where you'd be able to get it either through that trajectory or potentially another one. So it's more that, or in those large, more extensive tumors, knowing that some of it we'll be able to get from an anterior intrahemispheric, but maybe the second through a transcelcal transinsular if it's sort of TransSylvian transinsular if it's a more inferior tumor that extended laterally instead of retracting so much on the brain.
Hello,
Please.
Professor Richardson. It's a super presentation. I have some question for you. This regarding the literature that radiation IMRT, they mentioned that there is no overall survival and progression-free survival, but not significantly different between two groups. That is the latest literature from China. That is this first question. The second question is that there's many reports of the neurocognitive impairment in adult thalamic glioma. What is your experience about this? And the third question is about mutation. They mentioned also that there is 48% of thalamic glioma detected with mutation, and it is shorten the survival. That is, and also the question is, if you from the MRI is suspected of this is a high-grade glioma, then you still do the surgery for this patient or not? Because the survival is very short. Thank you, Professor Richardson.
Yes, so I'll start with the last one first. On the MRI, even if we suspect high grade, we will do surgery. And I think it's important to have a diagnosis for the patient and their family as well, just to know what to expect. But we have had some, again, prolonged survival. And again, that's in a small number of patients and isn't everyone. But in the patients we were able to achieve gross total resection, they did have increased survival. Now, that is which is the chicken and which is the egg, were we able to get a gross total resection because of some other underlying factor that would have improved their survival anyways, or is that the reason? And I don't think we have the information to tease that out, but I think giving patients the best chance you can if you're not hurting them is certainly worth doing. In terms of mutations, unfortunately, this study, some of these patients were from 2016 or earlier, and so we don't necessarily have molecular data on all of these patients. It is sort of a limitation here that it was done sort of before some of those newer WHO guidelines. So we don't have all of that. And in terms of the neurocognitive impairment, I think that's a fantastic question. That's something I'm very interested in, and I don't think it's just the Lamicliomas. I think it's anytime we go into the brain, we certainly have risks of neurocognitive impairment. You know, the neurosurgery exam of their walking, their talking, you know, we succeeded isn't really, I don't think should be the mark anymore. We've done well enough. We know we can keep patients alive through surgery. This isn't, you know, back when 50% of people weren't making it off the table.
Do you use awake surgery for? Do you use awake surgery?
We haven't. I think these are long cases, and if you're not doing cortical entry, I think it's probably a little bit tough. And I think the neurocognitive effects are going to be things that are tougher to tease out. I don't know what it would change. I think it would be difficult to assess whether it was the anesthetic. It's, you know, certainly for motor and things like that, we have good ways to monitor that while they're sleeping. I think the more nuanced neurocognitive effects are things we really need to examine probably in all our patients post-operatively, but people aren't necessarily willing to sit through the large hours required for a real neurocognitive battery of tests. So it's certainly difficult. And was there one more question?
Radiation, IMRT group. The comparison between surgery and only IMRT group.
Oh, okay. I haven't seen that study yet, but I think it's, again, I think all these comparisons are worth doing. I think it's just tough because there aren't that many of these patients overall, and to really do a good comparison study of tumors is difficult because one thalamic tumor isn't necessarily like another thalamic tumor. They extend into different areas. People have different symptoms. And I think surgery at least has the potential, and we haven't demonstrated this in any real way, but in these larger tumors, removing some of that mass effect and hopefully alleviating some of that edema might allow them to tolerate radiation better. I mean, we know surgical resection is not a cure for high-grade gliomas.
Yes, one more question. In your experience, did you ever refuse for surgery and you send for MRI in in which case like this? For radiation. You
There are
refuse
certainly
surgery, you don't
patients.
want to surgery. Yes.
Yeah, there are certainly patients who that's happened for. I think that's more common in patients who come to us for a second opinion, either after a biopsy where they were told nothing more to do, who've had sort of rapid progression of their disease, because I think we're always confronted with, is doing more surgery better if it delays the treatment, that ultimate treatment of radiation and or chemotherapy, which we know are sort of the more treatment options. Like I said, surgical resection is never going to be a cure for high-grade glioma. It's everywhere by the time we know it's there. So if people are having rapid progression of distal sites of disease or something like that, I think it's more important to get them onto those adjuvant therapies.
Thank you very much.
We can go back to Professor Narita.
Okay. Regarding to the staged surgery, have you tried two-stage surgery for glioblastoma?
Yes.
Yes. So how long is the interval between two surgery for glioblastoma case?
I would say
1 week or 2 weeks?
ideally less than 2 weeks. Some of it depends on how the patient's doing. I think if the patient's not doing well, you can make an argument to maybe not pursue additional staging. But if the patient's doing clinically well and they have some residual enhancement that you think is accessible, I think it's reasonable to go after that in certain circumstances. And I think the shorter interval is better because, again, you don't want to keep delaying those adjuvant therapies. And it prevents scarring. So you're not dealing with a scarred in mess of tissue, which is obviously always a challenge.
Okay. I have a last question. So you show the supracerebral approach for thalamic glioma. What is the difference between supracerebral approach and occipital interhemispheric approach? What is the point to select those approaches?
That's a good question. So the occipital interhemispheric is better for some of those more posterior superior lesions, more centered in the pulvinar, whereas the supracerebellar infratentorial gives a more inferior trajectory. So some of that depends on if it's extending into some of these adjacent areas, which might be better. And also their visual status preoperatively could potentially weigh into it if you thought you could get it through either approach. The supracerebellar infratentorial approach is quite uncomfortable. I have to say, I think the occipital interhemispheric is ergonomically better for the surgeon. So there's different pros and cons to each of them.
Okay.
May I ask a question, a little question, quick one?
Yes, sure, why not?
Right. It's just with regard to the superior parietal approach, lobule approach. What was, from your point of view, Professor, what was the main disadvantage of that? I mean, why it wasn't your preferred one? Is it because of it's really long way, or just the subsequent edema, perhaps because of retraction and all that? Because I thought that was a good approach for lots of things, not only for thalamic tumors. Superior parietal lobule is not a bad one. What's your comment on that?
It's not a bad approach. I think it just has to be used appropriately. I think some of these tumors that are more extensive inferiorly, you do end up with a really long reach, and it's sort of, you're going through this transcortical trajectory. So the working angles, and like you said, the retraction, and if you're on the left side, I think it can be sort of problematic as you're trying to work in that deep, narrow hole, sort of through a dominant hemisphere. I think right-sided, it's less of an issue. But like that cyst that went almost to the surface, I think it's a great approach for that, because now you're working in this big cyst cavity that came almost to the surface. So that's certainly an easier one. But something that starts out very deep, I think it can be a little more challenging for that approach than some of the others.
Right.
Thank you very much. We can have your concluding remarks from Professor Narita.
Okay, it's very nice presentation. So maximum safe resection is very important, even for thalamic gliomas. Let's try. Thank you, Dr. Richardson.
Thank you very much. It was an excellent lecture, very well covered all the different aspects of thalamic gliomas. Congratulations, and thank you very much for this wonderful lecture. We can go to the second session, and I'd like to invite Professor Abdul Hafid Bajmal to say the introduction part.
Yes, dear colleagues, friends, speakers, let me some short remarks for the ACNS. Talking about ACNS, I will never forget Professor Tetsuo Kano, his outstanding role in helping development of neurosurgery in many countries for decades. Likewise, special thanks for Professor Kato, and I would like to express my special appreciation to her support and contribution in the field of neurosurgery, especially in Southeast Asia and Asian countries. Also, Professor Lee Boon Seng, Assistant Secretary of ACNS, which revived communication between us. Now, I will continue with my introduction about Professor Jamal Ghoze. Now, dear colleagues, there is still many countries that are included in low and middle income countries, which are still difficult to properly regulate the healthcare system in their countries, such as infection rate and time response for trauma, early detection of brain tumors, early detection of unruptured aneurysm, and extra. And of course, you cannot possibly imagine how difficult it is for Professor Jamal Ghoze and his colleagues, neurosurgeon in Palestine, who's in conflict area. So the suboptimal utilization of peripheral healthcare systems, strengthening the integrity of the facility with this tertiary center, and avoiding overburden in the tertiary center, better implementation of prevention of disease like head injury by throat safety and etc. So Professor Jamal will talk about this in his experience in handling various neurosurgery cases in difficult situations in his country. There are still many countries experiencing internal conflicts and clearly seen as disregard for human rights. The problem we are facing is not only the barrier of the neurosurgery services, but the risk of loss of life for colleagues who are struggling in health service, including neurosurgeons. Now we are pleased now to have your presentation, Professor Jamal Ghoze. To our participant, please give your comment and question through the Q&A button or raise your hand, please. Thank you.
Hello, good time everyone, wherever you are. I'm Jamal Ghoze. I'm delighted to address a talk today to my international colleagues. I'd like really to thank Professor Yaku Kato and all the other professors and speakers and the audiences and the organizing committee members, of course, for their efforts towards such an event. Let me just say it's really difficult, as just my colleague just mentioned, difficult to talk about such a topic. I'm a Palestinian. I was born in Jerusalem, and this is a quick view of the city. I'm sure most of you must have visited or seen. This is where I'm based at the moment, although I'm quite a frequent traveler. Just before I start, I really would like to message to my colleagues across, whoever is hearing across the world. Basically, beware of turning our profession into a business. This is unfortunately, those who work in the private sectors, they're aware of this more than those who are really in public. Again, the knowledge is, the background knowledge is really, is quite really important, and keep your ethics intact. The active practice of neurosurgery is overwhelming. And should be patient-centered. Explain to the patient with particular emphasis on the risk-benefit ratio. I understand there are neurosurgical school of thoughts, different ones with regards to indications of surgical procedures. Again, the ongoing commercialization, along with perverse financial incentives, threaten to convert medicine into a business, while exploiting and taking advantage of the patient in need which really stands completely against our principles as surgeons. Let's not be driven away by misleading sense of superiority and the fascinating financial rewards. Some of us probably get more than others. That results in an egotistic feeling upon caregiving of a need. Neurosurgical practice should be patient-centered again, bearing in mind the good intentions always. Again, summary of life in general, if you like, it's devotion to the creator and striving for the benefit of the creation. So, okay, let's come into challenges in neurosurgery in suboptimal conditions and disaster times. I really struggled into what to talk about this because it's really difficult. There are many aspects, but let's put aside the developments in neurosurgery, neurosciences, the latest advances in neurosurgical practice, the supporting subspecialties to neurosurgery. They're all, of course, contributing, and they're all something to enjoy. But I believe that neurosurgery service remains a luxury care because vast majority of the world population. This is just a picture of by the neurospace. I mean, basically, these are very advanced things, costly, etc. A lot of people, they don't, across the world, they don't have even access to the basic investigations, even before reaching that. Life is full of challenges. Life is always a big challenge, right? From the first breath you take in to the, it's all challenges. And again, if we're talking about neurosurgeon, right, once you finish your residency program, you struggle. You thought that you finished a big challenge, achieving your board or whatever degree, and then once you get a job, you struggle again within your hospital, within your clinic, again, financial rewards, burdens, all sorts of things. There's all challenges to neurosurgeons. It's not only surgery. Life around the neurosurgeon is really a challenge, a big challenge. Again, building up your career, it's an ongoing dilemma. We're all living and we all know about it. Again, the big challenge being up to date academically, catching up with the developments in neurosurgical practice. These are challenges. I just wanted to mention that before we go into the other different types of challenges we're talking about today. Now, witnessing the contradiction. Now, there are lots of luxury things in this life. But again, on the other side, if you look at the other part of the coin, life is not really as we wish, as it is. I mean, we wish different. Let's talk about, robotic neurosurgery, the latest advances into this, and interventional neuroradiology here and there, and really fascinating things. And we really like to learn more about it and get really enthusiastic to get our hands on and practice it. Again, cortical mappings and all these fascinating things and localization of the focus and all that. This is really nice to think about it. But let's again bring the other part of the coin. This is an OR. This is a picture I've taken in one of the African countries, I think in southern Sudan. That's a real OR, believe it or not. This is where they operate. I'm not talking about capitals in these cities, but we're talking about majority of countries. They've got really very, very limited resources. Through physicians across continents, it's a London-based organization I'm going to talk about briefly later on, but they are present in more than 42 countries with variable facilities and resources. Things have hopefully are changing to the better. Again, let's talk about one type of challenge. One type of challenge is countries with non-existing this is how I categorize them, just to make things easy. Countries with non-existing neurosurgical services at all. countries with severely suboptimal resources and deficiencies. Again, there are countries with basic but suboptimal resource. They're potentially upgradable. And there are countries with reasonable world average neurosurgical resources. So this is how I found things in these countries. Now, human resources, neurosurgeons, neurosurgical support team, the nurses, etc., and all these support services to neurosurgery, they can be non-existing at all, or they can be existing with variable degrees. Again, just a quick look at this slide. Having a neurosurgeon is really a big achievement to any country. Because if you look at, I mean, I've been, just before the COVID-19 crisis, I've been to Malawi. Malawi is a country in Africa. There are about 20 million. Neurosurgeon and one qualified neurosurgeon, and I think always around even traveling here and there. So basically, if you compare in Uganda as well, before that, and I just saw really few neurosurgeons for a country of about 550 million. There are big differences, big gaps really, if you compare it to more advanced countries. Again, challenges, it's not only with the availability of neurosurgeons and the team, it's challenges with the availability of the place. There may be no places whatsoever. I mean, so patients, neurosurgical patients, don't find hospitals even to be treated at. Again, the place either totally absent or can be really very basic. These are real pictures. Now, neurosurgical equipments, again, when it comes to equipments, they can be not existing at all, or they can be very basic general surgical equipment, very basic neurosurgical equipment like Gliso and all these old ones some of us might be familiar with. And again, with the help of the WFNS, at some stage, we found basic neurosurgical setup of the WFNS. And again, an advantage on the top of that is getting a microscope, again, sponsored by WFNS to certain countries. The other challenges can be, type of challenges can be natural occurring disasters, floods, earthquakes, etc. Again, occupations, unfortunately, this is man-induced, civil wars, motor vehicle accidents, and traditional trauma. We cannot do much about this, although more awareness into regulations will help reduce, but the man-induced ones are a bit bitty, and it's a shame on humanity to not to solve this yet. Physicians Across Continents is a charitable organization, it's a London-based one, probably talk about later on. Now, another challenge is communication. It's a big challenge in these, let's say, countries with suboptimal services, or the so-called third world countries. Now, the communication even to try to improve the facilities, try to upgrade the system, try to help others, and you have a communication problem, a communication challenge. Access to facilities. Sometimes a country does have facility, but still they don't have, you cannot really communicate. It's bureaucracy, it's international politics dictated donations. There are many other things one can talk about, unfortunately. I don't know who's responsible behind for all this, but these are real challenges. Even if you have the resources, if you have the resources, if you have the facilities, but still you're faced with implementing these resources because of regulations, whether internationally or nationally, and politics, and etc. Again, how to tackle some of these challenges I mentioned, tackling and coping with these challenges. Now, when it comes to human resource, group of neurosurgeons can move with their teams, anesthetists, scrub nurses. This is what actually Physicians Across Continents have been doing. They identified that challenge and they're working on it by traveling to the area. This is just an example of one visit to one of the countries in Asia. I think that was in, can't remember, Bangladesh, or I think visiting the Myanmar refugees in Rohingya. And again in Africa, this is what one of our colleagues, I think, yeah, she's from Queen Square in London. She was about to graduate. She just was telling about her experience in one of these visits. Again, the consistency of services. As we all know, give a man a fish and you feed him for a day. Teach a man how to fish and you feed him really for a lifetime. So that's the principle we're doing. So lecturing at the universities, talking to these people, trying to leave a good impact behind you so that they can really work on themselves. And when you come back for your next visits and surgeries, really yourself, you can even improve on that. Again, making relations with professors, university professors in their countries, across the countries you visit, that helps a lot. Workshops, seminars, and or teaching in OR. These are our neurosurgical colleagues teaching local staff. You don't have to wait for a well-structured formal program. The goal here is really we need to save lives. We need to improve the service. The formal training, the formalities in the advanced countries trainings and all that, if you wait really until you achieve all that to the standard we really want to, we're not going to achieve anything. We don't want to do this sophisticated thalamic glioma surgery in a country which they don't have a good microscope, or they don't have even a good high Tesla MRI or so on. So we need to move. We need to be effective. Our life is really limited. We need to score as much as we could in that regard. Again, as I said, workshops. And one of the things really PAC implemented is that you go to a country, identify the potentially upgradable staff, doctors, nurses, etc. You take them to another country who can. I mean, we have examples of this. Sponsored in Jordan, for instance. They're from Africa, and some in Morocco from Republic of Congo, and some. So it's not only for neurosurgery, but these are programs for everywhere. Again, external examiners, you can be by helping and support your colleagues and staff in these countries. Yes, it's different teams. Again, if you don't have, when it comes to the equipments, basic equipments, the first visit is usually difficult. They bring their own. This is a neurotraumatologist, a maxillofacial surgeon from Jordan, and traumatologist from Manchester, one from London, an engineer. They're all traveling with their basic setup. To carry on, to start, to at least to bridge the gap for others to come in. I know working in places like Queen's Medical Center or in Nottingham, Queen Square in London, or King Faisal Specialist Hospital and Research Center in Riyadh. These are very advanced places, very advanced centers. Unfortunately, it's not the case really in these remote areas. Again, it's not only saving life, but by doing hydrocephalus and all that, but again, patients with this is a patient in a tent having multiple neurofibromatosis, having lots of pain, agony because of impingements on his nerves. You really can do a lot, I'm sure, if you spare some of your time and your holidays and leaves to these places. I've seen Foley catheters being inserted into head and the suction tubes of the anesthetist instead of VB shunts and instead of EVDs and the stuff we're used to. Again, other types of challenges, having different types. You get used to different types of gunshots, and again, we're working hard towards improving our neurosurgical services and towards latest in neurosurgery to implement it on our practice. And those on the military side, they're working hard again in improving the types of bullets, how to make maximum damage without killing the patient, because this is again they want they're after disability and all that. It's a very unfortunate world, very, very hypocritical, and this lots of discrepancies. These are types of shots, they're really causing remote effects, and with all these chemicals in them and all that. But believe it or not, at the end of the day, there's nothing better and nothing really nicer than having than treating a patient and relieving his pain, relieving his agony. It's a feeling, you as a neurosurgeon, as a surgeon in general, that you have, you cannot really describe it. You feel the life. You really have a taste of, like when we operate on a patient impending paraplegia and he's up on his feet again, that sort of feeling. Just remember that feeling. If you live it all the time, you just have a different taste of life. Again, if you have facilities to mobile clinics, that's wonderful. There are ORs within a mobile clinic in these countries or in these places where you cannot really afford having full-blown places. Now, one of the examples PAC physicians across continents implemented in Nigeria just 3 weeks ago. They started building part of their project for cardiac surgery and neurosurgery. There are many other areas. Of course, that all depends on donations and depends on making rules easier towards such things. Again, one extreme and serious and profound challenge is that this is really a special challenge, that when countries have the above average and even advanced resources, but both the caregiver and the patient are vulnerable to real threat of physical existence. They represent the worst unescapable challenge. That is the worst challenge one can ever see. This is a few weeks ago. In the middle of the world, in a country in the middle of the world. This we witnessed that in Gaza. That's not a secret. Everybody saw that on TVs, and we witnessed that. I don't know how to tackle such a challenge. Basically, I don't know how to describe it. But now this is one patient, for instance, is with a gunshot, special gunshot. I don't know what it is, but. He presented to the ER. I saw him with a brain outlet, small, and the patient was alive. And then you just run with him to the OR, try to see what happens, and then you'll be surprised to find the bone is just crumbled into pieces, and it just once it finds resistance, that type of bullet, it just destroys everything, and so this is the picture can tell you there are tens and hundreds of examples of this. But this is again a live patient. You can't just leave him without any management. But when brain, as neurosurgeons, when brain, you have a different look at the brain. This is not the brain we see in elective cases in places where there's some stability. Again, this is, okay. So I don't know how to tackle these things, but one of the certain organizations like PAC, Physicians Across Continents, they're trying to help as possible. And I'm sure there are many other organizations they're trying to help. This is a London-based organization. It's Physicians Across Continents. They've got conference hall. They've got halls for workshops, train surgeons before they go to these countries, try to help. The values here are, whoever saves a life, it is as if he is saved the whole of humanity, serving all, regardless of gender, race, ethnicity, faith, etc., through compassion and respect. Again, in PAC and these charitable organizations are trying to get partners as possible. But again, funding is really unfortunate. Lots of surgeons, they travel on their own expenses. there are lots of projects. They need funding and expansion. At the moment, they are working in more than 42 countries and 300,000 surgeries, not in neurosurgery, of course, but in all specialties. Neurosurgery is part of them. Again, one of the challenges you might find is that you don't have facilities to imaging. A patient with a head injury, you take him to the OR straight away because of, let's say, gunshot or brain outlet, and then you realize that he's got a cervical injury. As we know, with all head injuries, there are always a percentage of 10 to 15 at least of cervical injuries. So these are challenges. Now, whenever funding is available, whenever you have screws for a very mechanically unstable back pain with agonizing pain 24 hours, you do your job. And again, whenever you have limited number of screws in these countries to a good number of patients, more than the screws needed on that particular visit, consider a unilateral fixation, consider a unilateral lumbar fusion. Again, it's been well documented in literature. You do it, of course, 4 screws better than 2, but again, 2 can do the job. They've done the job lots with me, especially with unilateral instability. Now, when you have a tumor like this, of course, you'd like to do a cortical mapping. This is a picture of Professor Jordan Gervin. He taught me a lot in epilepsy surgery. Now, you'd like to do a cortical mapping with all these intraoperative electrocorticography, localizing the cortices. But again, if you don't have the facility, remember that to tackle this problem, go for an awake craniotomy. So I encourage all neurosurgeons in these countries to try to learn more about the awake craniotomy. It's a little bit, of course, with the advances of anesthesia, we all like to have the patient asleep, but really, believe it or not, let's revive awake craniotomy. We can do lots of things with awake craniotomy. Again, awake craniotomy saves you lots of post-op problems, complications. You don't need that very sophisticated intensive care after surgery in awake craniotomy, as you're aware. So this is just a message that awake craniotomy can be an answer, really. For that particular tumor, for instance, all you need is, again, having a bipolar cortical stimulator. It helps. And here where I put, this is sensory motor cortex, just put it down, and you can do a lot by doing this. Again, patients with congenital anomalies on the spine, craniocervical decompression, whenever facilities available, we do fusion. We do this. You can do that. If you have, again, the nice thing to do with your cranioplasty, you do it. Otherwise, you leave the patient with bone cement or leave him without anything, again, subjecting him for further trauma. Again, one thing really you can come across in these countries is that patients with infantile hemiplegia, because of whatever reasons, mechanoencephalitis, because of Sturge-Weber's, because of whatever goes, and intractable epilepsy. You don't need to have all these sophisticated advances in neurosurgical investigations to reach your specific goal. And so let's, jump over all that and remember that with functional hemispherectomy, we can do a lot. We can save a lot of children. Let them be paraplegic, quadriplegic, hemiplegic, that's fine. But you save them from having intractable epilepsy all the time. And lots of patients have been operated on them through functional hemispherectomy. They are hemiparetic and they're up on their feet and walk, but they are seizure free. All you need to do is, the point here is that you don't need to have sophisticated facilities for such a surgery. You need just your hands, you need how to do the surgery, and that's it. And what's really needed here is you do, for instance, a radical temporal lobectomy. You do transventricular corpusculotomy, a Rolandic window, anterior orbitofrontal dissection, and posterior parietal occipital functional disconnection and all that. So this can be really help. Again, with a child who's got a severely, a very intractable seizures with bihemispheric foci that you cannot do anything. Remember, corpus callosotomy is not a very difficult surgery to do in terms of you don't need facilities, you don't need intraoperative recordings, you don't need anything. All you need is just to do a simple craniotomy, as we all know, and remember not to exceed the anterior 2/3 of the corpus callosum, and then you really get good results. So again, subpial transection. If you have the frameless stereotaxy, that's fine. If you don't, go for the frame. If you don't, just per patient's a place where you can. That's a picture of I took in Arkansas in the state. This is the microscope of the Professor Ghazi Yazarjil. This is where he started his microscopic surgery, and then after that things have really developed. Now we're going to and basically development in IT and development in technology is going really to help a lot these countries, the poor countries, the places with poor facilities, because you don't need to. I mean, this is, for instance, the an infrascanner intracranial hematoma detector. In trauma, you just bring things at the scene, and then you can identify at some stage whether you're dealing with a hematoma into that brain, which side, and then you may save imaging upon arrival to the ER. And again, this is Japanese product, I think slightly into market, where they have you have a scanner, you hold it in your hand, and then you just use it and connect it to your mobile phone, connect it to your tablet, you take it with you to the scene, it does the job. It's not readily available, but the point I'm trying to make here is that if you have such developments in technology, again, you will really bridge the gap and to wherever facilities needed, and keep these children happy. And they don't have to go through all the steps the advanced countries have gone through to be helped. So the one end of the spectrum, one end of the technology can help them in the back. God knows where we're heading in terms of technology and advances, but hope that will be for the benefit of us, of human beings at the end. We do it in the right way, we can help others. Now remember that we're all human beings at the end of the day. We are educated human beings, and we are medical doctors, and we are neurosurgeons. But unfortunately, some of us forget that base, forget the human being thing. It's easy to say that we are human beings. It's easy to say we are humanitarians. It's easy to say all that, but believe me, and it's easy to admit, but sometimes it's difficult to practice it. Challenges tackle perso game unintentionally diverts us from the base again. Unfortunately, with justifiable, convincing excuses. There are always excuses behind not helping others. What's the idea behind our existence in this life? Looking at ourselves being the elite in the society, then if we are the elite, and if the elite are not considering a change, who else would do? A serious, alarming responsibility. Remember, we're all transient in this life, whether we like it or not. Now, this is my final slide. Now, conclusion and perhaps the take-home message. Neurosurgery remains non-existing or a largely restricted service to vast majority of our globe inhabitants, unfortunately. There is no substitute for expanding knowledge and education being the basic pillar of hope towards tackling challenges. Again, advances in neurosciences, neurosurgical practice bridge the gap between the advanced and suboptimal facilities. As I mentioned, there's good hope, really, we're putting a lot of hope on that. Again, witnessing the international politics dictated bias against the needy countries should motivate neurosurgeons towards more giving and charity work. Again, if if you cannot visit a country, if you cannot be part of those directly helping, if you cannot do it yourself, help others do so. If you cannot even do that, encourage others and spread the noble message. Again, talking about challenges finally in neurosurgery and its different types should motivate us more and more towards further understanding of the sufferings people have across the world, whether naturally occurring or unfortunately man-induced, and sacrifice more of our time and efforts towards such a humanitarian cause. Being a neurosurgeon and being looked at as the elite, we have a major responsibility towards others to relieve patients' suffering and help reduce the impact of disasters on victims everywhere, without exception, and exert influences as possible on concerned bodies and policymakers to achieve our humanitarian goal at the end. Colleagues, by doing this, that is the real message we are conveying to the world and our real objective of life and existence in this life back to track. Wish you all the best. Thank you and enjoy your time. Thank you for listening.
Thank you, Professor Jamal. Thank you very much for your representation, especially your important message of the ethics. Now, actually, I'm anyone from the speakers will give a question to Professor Jamal.
There has no hands been raised yet.
No.
Dr. Liu, would you like to ask something?
I want to ask Professor Jamal. I expect actually more about the neurosurgery in Palestine, especially in Jerusalem where you work. How about the organization? How many neurosurgeons do you have, and where will their training happen? And I saw also a wake surgery and cortical mapping, craniocervical fusion. Is it in your operating theater or from different operating theater? Can you
right? Right, thank you. It's basically what I wanted in this lecture is not to direct or focus on a particular country. I'll tell you very, very briefly about Palestine, but because my experience has not been in Palestine only. It's been, I was born in Palestine and in Jerusalem, and then grew up. I came from a family background. My father was a doctor, and got lots of surgeons around me. I had a chance, a privilege to go to other countries and get more experience into neurosurgery, etc. But when I came back to Palestine, I mean, in Palestine in general, I'm talking about the Palestinians, of course. 30 years ago, there was one neurosurgeon, I think, or two. Later on, number got a little bit more. I'm talking about the Palestinians in Palestine. The Palestinian neurosurgeons outside Palestine, they're really in huge numbers. Now, why can't they come back? For many, many reasons. Simply, they cannot come back because they're not. They don't have the right to go back. Although they are Palestinians, we don't go into this now. Again, some of them come on regular and irregular visits to help. Now, when I came back about 10 years ago here, less than 10 years ago, I was perhaps the fourth neurosurgeon here. Now, we've got a Palestine Medical Council on bringing more. So in 10 years, now we are about 15 or 16 neurosurgeons. But before that, over 30 years, only 3 or 4. So there are good facilities. We've got equipments. Yes, awake craniotomies. I carried out this craniocervical fusions carried out here. Again, palazotomies, etc. Yes, we can do that here. I'm not talking about all the cities in Palestine, but we have good facilities because there are well-equipped, there are well-qualified neurosurgeons, and Palestinians are quite well educated. So the problem we're facing here is the availability of resources to the right place. The other thing is how much you know about Palestine, but let's happened in Gaza a few weeks ago? What happens every now and then? It's difficult. Again, funding is extremely important. I cannot develop epilepsy surgery in this country simply because lots of equipment's needed, lots of teams needed to train. So that's the situation in Palestine. You can be working on a difficult tumor, like you're doing it anywhere else in the world in advanced cities, but suddenly you're confronted with huge number of patients with head injuries because of whatever disaster happened here or there, and that's very brief. I don't want to go into the Palestinian issue too much, but it's very complicated. But most of the experiences I've shown as well really concentrate on countries in Africa, in Asia, refugee camps nearby, whether for anywhere. It's the same principle applies. So yes, did I miss anything? Any point you really wanted to ask about?
It's not enough.
Yeah.
So I think if there is no question, I will give some short remarks that difficult countries have different challenges. You mentioned about that, and especially the human resources and extremely suboptimal standard of facility and resources. And also the other problem is the bureaucracy and politics. That's the barrier of the development of the surgical service in suboptimal country. And I think there is more information from you about the ethics, about how the problem in suboptimal country in Africa, your experience is very important for us. And I think the organization like ACNS and World Federation should make a good cooperation. So what you mean, like visiting neurosurgeon team and workshop and seminar to that country, yeah?
Yes.
I think that is my short remark for the important and historical review of Professor Jamal Goseh. Thank you very much, Professor Jamal. And thank you for the speaker. I give once again to Raja, please, Raja.
Right, thank you very much. I think it's time now we wind this up. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to sincerely thank both the speakers of today, Dr. Angela Richardson and Dr. Jamal Goseh, and the chairs, Professor Yoshitaka Narita and Professor Abdul Hafid Bajmal, for the time and support for the ACNS webinars. I would like to thank my co-host for today, Dr. Liu Bun Seng. A special thanks to Professor Shubin from China, who has been our main mentor, and he has arranged this broadcast of WeChat of this webinar in China. And today there are 1,100 people who are watching this live on various streaming platforms on WeChat, YouTube, and Zoom. So thank you very much. So until we all meet on the 17th of July, it is bye-bye from all of us. Thank you very much for joining.